Good afternoon, everyone. Welcome to this webinar. I'm John Samet, the Dean of the Colorado School of Public Health. For those of you who don't know me, my background is in epidemiology and also pulmonary and critical care medicine. And for the last 2.5 years, I've had the honor of being Dean of our collaborative school. Today's webinar is a bonus, if you will, an extension of National Public Health Week, which was last week. We, of course, couldn't let that week go by without talking about the COVID-19 epidemic. I think few of us could have imagined that we would have perhaps 1,000 participants listening from our homes and speaking from our homes on April 13th of 2020, talking about this epidemic. Additionally, with the temperature outside of about 20 degrees and snow falling. I want to introduce our participants. Beth Carlton, Assistant Professor in the Department of Environmental and Occupational Health at the School of Public Health. Beth is trained in environmental health, receiving her PhD at Berkeley and MPH from Columbia, and has an interest in waterborne diseases and disease eradication, and has used the modeling tools in her work that we'll be talking about today. Also, we're fortunate to have Rachel Herlihy with us. Rachel is currently Division Director of the Communicable Disease Branch at the Colorado Department of Public Health and Environment, CDPHE, and also the state epidemiologist. Rachel received her undergraduate and MD degrees from the University of Wisconsin, completed a preventive medicine residency and MPH at Johns Hopkins. I will say that both Rachel and Beth are representing the work of many. We've had a team doing modeling that has involved the School of Public Health, the School of Medicine, the University of Colorado, Denver, and Boulder. And of course, at CDPHE, there is a very large team and others from state and local governments working on this crisis. I also ask that for your questions, we're going to try and leave at least 20 minutes for questions and discussion, put them into the Q&A, and I will try and track them and summarize them for us. I'm going to go on and just make a few introductory comments and then turn to Beth and Rachel. Next slide, please. And this is one of those moments where none of us need to say what it is we do. We are at a moment where everyone knows what public health is and everyone knows what epidemiology is. A relevant quote from a former Colorado governor and a cartoon. Next, please. Now, I can't talk about epidemics without going back to Jon Snow, not the one from Game of Thrones, but the physician epidemiologist who discovered the waterborne transmission of cholera before we knew there was such an organism. Here's a description of his efforts. He actually didn't remove the handle from the water pump, but suggested that he should. And I think this illustrates the role of the science we do as public health researchers and professionals in guiding policymakers. Next, in the paradigm that follows from Jon Snow, there was a cholera outbreak. He gathered evidence, some of it coming from the famous episode with the Broad Street pump, and inferred that water transmits cholera and recommended removal of the pump handle, and then tracked. And here we are today, following some of the same steps, and already huge progress has been made on understanding the SARS-CoV-2 virus and the disease it causes. And we're going to talk today about the evidence we have, its translation, and the follow-up steps. Now, I will point out that one disease has been eliminated. D.A. Henderson led the smallpox eradication campaign, and some of the methods that we use, particularly surveillance, contact tracing, identifying where the disease was coming from, were critical in the ring vaccination strategy used by those who eliminated smallpox. Next. Now, what we're going to be focusing on is evidence, what we know, and what we don't know. And here the models that we're going to be talking about are a way to fill some of those gaps. They, of course, come with uncertainty. And next slide, this all figures into policymaking. And I often use this slide in talking about how evidence and uncertainty figure into policymaking, as do many other things. Next. And so it's going to move around a little bit, but here, central to decision making is what the epidemiology tells us, what we see, and what the models predict. And then, of course, the other important part of this balancing the consequences, the economic consequences, the human costs of the epidemic. Next. So models are critical here. We have a new epidemic. We don't know, based on past experience, how it will play out, but we have ample experience in using models for many different epidemics, and Beth will be talking about that next. And just as a reminder, a model is a model. We are just representing the world as we think it is, taking our best guess at building a mathematical statistical representation. A few cartoons, and then this noteworthy quote that I've used a lot these days when we talk about model results. All models are wrong, but some are useful, from the British statistician George Box. So I think that's useful as you read about sort of competing models and which one is right. Well, remember, all are wrong, but hopefully we're using some that are useful. So with that, I think we'll move on to Beth's presentation. So please, Beth, go ahead.
Thanks, John. Next slide, please. So I'm going to talk a little bit about our response to the COVID-19 here in Colorado. When we were approached to assist with modeling for the COVID-19 pandemic for Colorado, there were several priority questions, and these really remain central, motivating questions. The first question is really about the peak and when it will occur. The second set of questions is very similar to that, and it's really about hospital capacity and our ability to respond to the epidemic. How soon will the peak occur, and how soon will we reach ICU bed capacity, which seems to be the biggest, most limited resource. And the third set of questions are about interventions and really how effective social distancing or other interventions we may implement may be in slowing the epidemic, reducing the magnitude of the peak, and ultimately preventing morbidity and mortality. Since the theme of this talk is epidemiology in action, I just wanted to point out that for very obvious reasons, there has been a need for rapid response. Our first deadline was 3 days after the team was assembled. And at the same time, we're trying to make projections about a disease that emerged 4 months ago. So the scientific evidence is evolving rapidly and certainly incomplete. And I'll talk a little bit at the end about some of our strategies for dealing with this highly fluid situations. But I just wanted to point out that we really have seen it as a priority for the team to try to generate estimates that we can stand behind and provide actionable information to policy members while trying to capture the range of potential outcomes and building models that can be adapted as our understanding of the situation changes. Next slide, please. So I just wanted to acknowledge the team. This has truly been a team effort, as John mentioned, and involves collaborators across the University of Colorado system. We have met frequently by Zoom and met many of each other's cats and dogs and kids as well. So next slide, please. So as John mentioned, mathematical models of infectious disease have been used for a long time, and they're often used at the beginning of infectious disease outbreaks. And one of the reasons for this is they can be created when information and data are limited. These are just a couple of examples using math models in the early HIV epidemic to really understand if a case is presenting with symptoms, how long ago were they likely infected? And a more recent example on Ebola of using mathematical models to estimate questions very similar to what we're thinking about now, about how soon will the peak occur and what will the resource needs be. In general, mathematical models of infectious disease can be used for 3 key things: to predict future disease, to define key features of a disease system, such as what is the reproductive number, what is the latency period, and also to predict the effects of interventions. So Next slide, please. So this is just a basic mathematical model of infectious disease. As you can see, there are 3 compartments, and everybody in your population can be in one of these three compartments. Everybody starts in the susceptible bin. As they acquire infection, they move into the infected bin, and then ultimately they can recover from the bin, from the infection, and if immunity is present, they can then be immune to the population. You can make this model more complex and account for example, death from the disease, so people can exit the infected bin for fatality, through fatality. You can have loss of immunity over time, so that people at some point in time can re-enter the susceptible bin. It's also important to note that that in mathematical models of infectious disease, the parameters and the equations are really based on biological, these parameters have biological meaning. And so we either derive these parameters from the literature or we derive them by fitting model estimates to observe data. I'll talk a little bit about what I mean on the next slide. So for example, we can create equations that describe how someone might move from the susceptible bin to the infected bin. And 2 of the main drivers of that are the contact rate, and this is really the rate at which infected individuals contact others in the population. In the early phase of an epidemic, they're primarily going to be contacting susceptible individuals. And you can also talk about the transmission probability. This is the probability that if there is a contact, that results in an infection. Not all contacts are going to result in a successful infection. Next slide, please. So you've probably heard a lot about the reproductive number by now. As a person who studies infectious diseases, it's fun that everyone now wants to talk math of infectious diseases. R0, or the basic reproductive number, is the number of infections directly generated by an infected individual in a population where you essentially have everyone who is susceptible and in the absence of controls. And the reproductive number defines on these 2 parameters we talked about earlier, the contact rate and the transmission probability. And it also depends on how long someone is infectious. The longer someone is infectious in a population, the higher the R0 will be. And as you can see in the schematic below, at the beginning of an outbreak, you have a high number of susceptible people, and gradually over time, the number of infected people will rise. At the peak of this epidemic, this theoretical epidemic, you have a growing number of recovered individuals. And as you move through time, you'll see that as new people become infected, they're less and less likely, just by chance alone, to encounter susceptible people, and the epidemic starts to slow and eventually ends. Next slide, please. So one of the key principles, and this is something we've really wrestled with in the modeling team, is this tension between parsimony and complexity. Ideally, you build the simplest mathematical model that can allow you to answer the question of interest. And so just like Picasso's drawings of these bowls, you can create a mathematical model with very few lines, or what you can think of as equations, and you can create a mathematical model with a lot of lines. The more lines you have, perhaps the more clearly you may be able to recreate your population, but the more you depend on assumptions that you're making. The more detail in your model, the more assumptions are needed. And so if you look at the next slide, we have focused our efforts based on a basic SIR model, but I wanted to point out there's a number of more complex models that are out there, and it's worth being aware of them. On the left, you see an example of a metapopulation model. These can be used to look at the spread of infectious disease across a network. And so what you can think of these as is simple SIR models that are connected so that you can account for import and export across different populations. On the right, you see an example of an individually based model. These are highly complex models that essentially model each person in a population and can allow for interactions at different scales, interactions within a school, within a home, within a workplace. and can be used to model complex social interactions and look at changes in those social interactions and how that might impact disease spread. So let me show you the Colorado model that we've been using. This is a modification of the SIR model. It's called an SEIR model because it includes an exposed bin so that people, after they become infected, have a period when they're exposed and incubating infection, but not yet infectious to others. Once an individual becomes infected, they can either be asymptomatic, and we assume these asymptomatic individuals circulate in the population. They're not undergoing any sort of isolation since they don't realize they're infected. And then you have symptomatic individuals, and we assume that there's some degree of reduction in contact because they recognize their symptoms, albeit imperfectly, and we could talk about that in a minute. Some proportion of symptomatic individuals will need hospitalization, and a portion of those will need non-acute hospitalization, and a portion of those will need an ICU bed. And we assume approximately 50% of the people who need an ICU bed will die. And then ultimately people enter in this recovered bin. So we can consider a couple of interventions here. One is what we've been talking about a lot in the community, social distancing or reductions in the contact rate. And we can also think about isolating symptomatic cases. These are two examples. I want to point out just that there's a number of assumptions we make in our model. All of these are detailed in the report we released last week, but I want to just highlight a few that I think are worth noting. We assume that the probability of developing symptoms and the need for non-ICU and ICU hospitalization is age dependent. That the older population is, the more likely they are to show symptoms and have severe disease. And this is based on some recent studies. We also assume that people acquire immunity after infection. We assume that the reported cases we're seeing in Colorado are not all cases of COVID-19 in Colorado. And then we also make this assumption that we'll discuss in a minute, that in the extent that we exceed ICU capacity, anybody who needs an ICU bed in excess of capacity results in a death. Next slide, please. So we can define a number of our parameters based on the literature, and then other parameters where there is the greatest amount of uncertainty, we actually fit using case data from Colorado. We set these parameter ranges based most often on the literature, or in some cases based on the epidemiological data we have. And then we use a least squares approach to estimate these parameters. And so I'll just highlight one of the questions we get a lot is what proportion of symptomatic cases are we likely detecting? And this model estimates that in the ballpark of a quarter of the symptomatic cases are being currently detected by case surveillance. And I would see that number as a ballpark. And I'll talk about this last parameter in the table in a couple of slides. Next slide, please. So one of the big questions has been, when will we see the impact of social distancing? And we know that if social distancing is implemented on a given day, we are not going to see that impact immediately because of the incubation period of the disease, because of the time between symptom onset and people going out and seeking a test, and then the time between symptom onset and fatality, and also the time between symptom onset and actual reporting of those cases. And so in Colorado, there really were two phases of social distancing implemented. The first one began in the middle of March. This was the closure of the ski resorts, of bars and restaurants, and casinos and gyms, and the gradual closure of different school districts. We're calling that phase 1 social distancing, and we assign that, for the purpose of the model, a date of 3/17. And then on March 26th, the governor shut down issued a statewide stay-at-home order, and we're calling that the phase 2 social distancing. And so we expect to be able to see the start of the impact of phase 1 approximately at the beginning of April, and we can talk about what we think that impact might be in the next slide. And then just to note, we think we should be starting to see the impact of the statewide stay-at-home order right around now. And one of our projects for the coming week is to really get a handle on what that impact has been. And just to be clear, this is the impact on cases and fatalities. There are other ways you can look at the impact of social distancing through cell phone pings and mobility that are being tracked now by others. So if we look at the next slide, one of our questions was trying to estimate the impact of phase 1, these early social distancing measures implemented in Colorado. And we did this through model fitting, using the reported case data in Colorado. We used the onset date of symptoms and using reported data through March 31st. To estimate what level of social distancing would generate the observed cases we see in the population. So you can see the red line is what we would expect to see in terms of reported cases, assuming some degree of underreporting, if no social distancing had occurred. And you can see we're already bending the curve, so we're not on that trajectory anymore. That's good news. And the best fit line seems to be about 45% social distancing for these phase 1 interventions. And again, I would see this as a ballpark, not a precise estimate, but there is evidence that the curve is being bent by these social distancing measures. Next slide, please. So because when we produced this report, we're not yet able to see the impact of phase 2, we used a set of projections about how effective social distancing may have been. So we said, okay, what if social distancing was 40% effective at reducing contacts? What if it was 80%? And what if it was, somewhere in between? And what if we hadn't implemented it all? What would we expect to see in terms of case counts? And then on the next slide, ICU need. And this is perhaps the area of greatest concern right now. If you look at the panel on the right, you can see a dashed line. That dashed line indicates our estimated ICU capacity of about 2,000 beds in Colorado. This could get ramped up over time. And you can see in the 40%, 50%, and 60% social distancing scenarios, we greatly exceed our ICU capacity. In the 70 and 80% social distancing scenarios, we stay below hospital capacity. And if we move to the next slide, this is the same information presented slightly differently. And I want to point out something that is worth noting, which is moving from 0% efficacy of social distancing to 40, 50, 60, we see the peak lowered and moved out further in time. Interestingly enough, when we see 80% efficacy of social distancing, we see a much earlier and much lower peak. And I'll show you in the next 2 slides why that may be the case. If we just look at the next slide, this is the estimated cumulative deaths under different social distancing scenarios. Again, this assumes that if ICU capacity is exceeded, any ICU need, we have an excess of capacity results in a fatality. And again, you can see the more effective social distancing is at reducing contacts right now, the fewer deaths we expect to have. Next slide, please. So this, I just wanted to talk through this flattening the curve versus bending the curve. As many people are probably familiar with this graphic that's been circulated, this idea that if we flatten the curve, we can reduce the number of contacts, reduce the magnitude of the peak, slow the infection down, and stay below hospital capacity. And there's some evidence that this is happening in Colorado. If you click, you can see that at 60% social distancing, we can so-called flatten the curve. But in this scenario, we still greatly exceed hospital capacity for a number of months in a perhaps catastrophic way. At higher levels of social distancing, you see actually we start to really bend the curve. So we have this rapid decline in infections and the rate of infections are acquired such that we have an early and small peak. This would be fantastic news if this happens. However, it begs the question that after we start to see infections decline, what do we do next to prevent a second wave of infections, because we will have a large susceptible population? So on the next slide, I just wanted to briefly mention the IHME model, since this has gotten a lot of attention. There's a model, this is a model put out by the University of Washington by the Institute of Health Metrics and Economics, projecting hospital needs and fatalities in different states. And there's a lot we could say about this model, but I think one of the biggest concerns about the model is they project that after this first peak occurs, we will be essentially done. And they have dialed back this statement, but they project that infections will remain and deaths will remain flat after that peak occurs, and even if we relax social distancing, and we do not think that is the case. Next slide, and I'll skip this in the interest of time. We can go back to this if anybody's interested. And I just wanted to highlight a couple of key findings to date. Social distancing implemented in mid-March appears to be slowing the spread of COVID-19 in Colorado. And we think we should be able to see the impact of the statewide stay-at-home order in the coming days. We really think the trajectory of the outbreak depends on how effective social distancing has been. The more social distancing we achieve now, the lower the peak, and the greater the potential to prevent mortality in the coming days. I think there are a number of priority questions on the next slide. And I've highlighted a few of them here. I'll just draw attention to the three that I think are most important. One is this question of social distancing and how long people will comply with it. And if we start to see a wane in infections, will people start to relax their social distancing? There are lots of questions about vulnerable populations, including disparities in health outcomes across race and across socioeconomic status. And we are really interested in understanding what's driving that vulnerability. Is this about susceptibility? Is this about exposure? And lastly, I think a real priority question is what additional measures are needed to prevent a second peak if social distancing, when social distancing is relaxed, and what's the best way to relax social distancing. So I'll just make a couple of final comments in light of epidemiology in action on the last slide here. We have really felt as a team, and I think I speak for all of us, the gravity of this situation. I think all of us are comfortable writing papers where we take months to ponder over our models and perfect every table and outcome. And we have really tried to come up with estimates that are actionable and implement strategies that can allow us to generate estimates quickly. Two of the strategies we've used that I think have been effective are running two models on different platforms in parallel to make sure that our estimates are not due to a simple coding error, and really focusing on being transparent about these assumptions and revisiting these assumptions often as our understand this disease and as the case data change. And I think I will stop there and hand this over to Rachel Herlihy, who will talk about how these models have been used to make decisions.
Thank you, Beth. Good afternoon, everyone. So as Dr. Samet expressed, this is one of those times in history when the world knows how to say epidemiology and knows what we do. Next slide. So our work is making headlines. Next slide. Including infectious disease modeling work. Next slide. It is, you can go to the next slide. It is being used on a daily basis to guide policy making and decision making here in the state. Next slide. And as public health scientists, we are fortunate to find ourselves in a state with science-minded and data-driven executive leadership. Next slide. So really since the beginning of this event, the governor and his staff have engaged public health scientists in policy development and decision-making. And when considering policy making in public health, we really balance the needs and possible impacts of those policies on our stakeholders with the evidence that we are generating and receiving from modeling in particular here. And it's a delicate balance. There is tremendous risk in following the will of stakeholders, especially just the will of the loudest stakeholders. We know that some are louder than others. And similarly, overly relying on just the evidence to guide our decisions. We need to carefully consider the impacts of those decisions on all stakeholders. And so it's a balance, and they deserve equal weight. So balancing the evidence we have before us and the needs of our stakeholders. In addition to lawmakers and governmental public health, it's really the people through elections and advocacy that are decision makers as well. And ultimately, in our free society, it is the people who decide whether or not they trust decisions that are being made by lawmakers and decision makers, and the policies that are implemented, and really decide whether or not to comply with those. They need to be recommendations that are trusted and that the people feel that they can comply with. Next slide. So I want to take a minute to talk about CDPHE and what we do. So our mission is advancing Colorado's health and protecting the places we live, learn, work, and play. We provide public health and environmental protection services with a focus on evidence-based practice and educating people so they can make informed choices on their own. Next. And a key ongoing priority, as outlined by our executive director, Jill Ryan, is responding to emerging issues and public health emergencies. And so here we find ourselves. Next slide. My slide isn't advancing. I don't know if you can hear me. Okay, here we go. So our communicable disease control work and my position as the state epidemiologist falls here where you see the blue circle in the department's disease control division, together with our state public health lab and our Office of Emergency Preparedness and Response. Next slide. So this description from the Council of State and Territorial Epidemiologists is a pretty precise description of my role at the state. Manager, health expert, disease investigator, emergency responder, public speaker, educator, convener, and public health advocate. And now, as much as ever, state epidemiologists are really at the interface of epidemiology and policy. Next slide. So those of you that are familiar with incident command will know that during responses to emergencies, often our normal org charts go out the window, and we really create new structures to ensure that we can effectively and efficiently respond. So this is the current incident command structure we are using at the state level right now. So at the very top of this organizational structure, you will see the governor. You'll see a policy group. I brief that policy team and the governor's office twice a day on the epidemiology and our understanding of medical impacts in the epidemic. You'll also see a unified command structure. And so we have integrated command and coordination across all state agencies currently involved in this structure. And then along the bottom, you'll see different sections. And so I'm currently in the public health and medical section, serving as the state epidemiologist. And it's really within that public health and medical section that our epidemiology and disease control work is occurring, as well as the medical surge work that we have going on to ensure that we have sufficient healthcare capacity in the state. So you can go to the next slide. This is the team and the structure that we are using for decision making. And this is really where the CU and School of Public Health modeling work really plugs in through me and through our department's executive director, Jill Ryan. So we're using the models to, as Beth mentioned, to help us predict when the epidemic will peak under various levels of social distancing, and also to try and understand what healthcare utilization might look like at the peak. Answering questions, as Beth suggested, such as how many ventilators might we need, how many ICU and hospital beds will we need, and how many deaths and cases might there be in the state. Also questions like how much testing should we plan for here in the state? So we're using data and evidence from this modeling work that the team has been doing, but really carefully interpreting it, understanding the uncertainties that come with modeling. We're balancing that evidence, you can go to the next slide, that evidence and data about transmission really with those stakeholder needs and the economic realities. We know that absolute interruption of transmission through complete social distancing is not possible, and that months of stay-at-home orders really can't and won't work for Colorado. So we are working to find the most elegant solution we can. So this really means finding those disease control interventions that can suppress transmission in the state without suppressing the economy. And the menu of choices that we are looking at to really try and find the right combination that achieves enough disease control without complete social distancing and a stay-at-home order are things like some level of continued social distancing and figuring out really who should be prioritized to perhaps continue to stay at home because of risk to their individual health or because of the potential to increase the burden on our healthcare system. So looking at perhaps the role for social distancing in certain populations, but not the general population perhaps going forward. Also trying to understand, how workplaces might adapt and use social distancing strategies and work at home strategies, and thinking about perhaps who should be prioritized to work at home in the future. So we know that, often it's the younger generations that feel perhaps most comfortable working at home. Many of us are doing it of all ages right now, but perhaps it's going to be individuals in older age groups or individuals with chronic medical conditions that should be prioritized to work at home for the next few months. Also key to our response is going to be rapid case identification and testing. We need testing to be widely available in the state to really help us inform and rapidly implement isolation, contact tracing, and quarantine strategies as really our main tools for disease control. Also trying to figure out how symptom screening can be used in schools and businesses to make sure that schools are healthy environments and businesses are as safe as can be, and that disease transmission is really minimized in those settings. And then I think finally, lots of questions still about the community use of face masks or other face coverings and how those might contribute to decreasing disease transmission. So questions about what the appropriate combination looks like and really how they can all add up to be enough. And while doing that, also simultaneously really trying to increase our healthcare capacity, really trying to increase that threshold of ICU beds in the state so that we can really allow some level of disease transmission to occur in the state. So that's ultimately our goal, really, to allow some disease transmission to happen and build immunity in the population, but to do it in a controlled way that really ensures our healthcare system has sufficient capacity and protects our most vulnerable community members. Next slide. Thank you. And I'll turn it back to John.
Okay, thanks. So thank you very much to Beth and Rachel for really setting us up for a good discussion. So there's one question I can actually answer, and that is, will the slides be available? And the answer there is going to be yes, and we are recording this and it will be posted. And there's a huge range of questions and comments. And what I'm going to suggest we do is sort of segment them by some of the questions directed at the model, some directed at sort of the course of the epidemic, and I think questions that will fall right with Rachel around sort of the later phase, what CDPHE will be doing, what about contact tracing, maintenance of masks, and some other things. So I'm going to suggest maybe we start with some of the modeling questions. I will just put on my very old clinical hat for a moment and say there are a few questions about critical care, the choice of the 50% mortality rate. That's actually very close to what's being observed and pretty typical of what is generally observed with adult respiratory distress syndrome. And yes, critical care capacity is being expanded, and new approaches are being found that hopefully will allow us to treat more and more people if need arises. Beth, one question I think that threads through a lot of discussion is just what is social distancing anyway? And how does it relate to the measures that are being proposed and used? And I think a number of the questions touch on that issue.
So this is a great question. We are undergoing an enormous kind of natural experiment or unnatural experiment of radically changing people's social contacts to try to reduce the spread of transmission. And in many ways, we don't know exactly how this is going to change people's contact rates. And what we're really interested in from a modeling perspective is how social distancing reduces the potential for infected individuals to come into contact with susceptible individuals. And that's the reason we've put in these percentage social distancing, which you can think of as a percent reduction in the contact rate, the percent reduction in the number of people you have face-to-face interactions with on a daily basis. And we've borrowed this percent reduction concept from other teams who have done something similar. But I think the real question is, how does this correspond with reality? And to be realistic, I think we will be better able to say if in a week or so how well the statewide stay-at-home order has affected social distancing. I think it's going to be much harder to untangle how different measures such as closing schools versus closing bars and restaurants really impact social distancing. And that's where a more sophisticated, individually based model might be needed.
So Beth, one more question that I think comes up generally, which is you've shown a statewide model, and the state, of course, has many different groups of people, some with differing vulnerability, susceptibility. And the question comes at, should we be doing, I guess, more refined models? And Rachel, you may want to weigh in here as well in terms of your potential need for, particularly in the later phase of the epidemic, for giving better, more structure to the model to acknowledge how heterogeneous our state is as are others. So, but Beth, why don't you go first and please follow Rachel.
Yeah, we've had a lot of internal discussion of this as a group and with others. I think, there's beauty in having a statewide model in that, for ICU capacity, for example, if capacity is exceeded in one region of the state, patients may flow into other regions of the state, and it's harder to capture that in a regional model. That said, I think we all agree that, an individual's contact patterns alone may look very different if you live in the Denver metro region versus if you live in the ski regions up in the mountains versus if you live in rural parts of Colorado. And so we've been thinking a lot about how best to represent the regional diversity of Colorado. But at the moment, I felt the need to generate statewide efforts. I don't know, John or Rachel, do you want to add anything to that?
Yeah, no, I would echo what you just said, Beth. I mean, I think we've been trying to also think through what makes sense in trying to model this in regions of the state. We know that it doesn't necessarily make sense to create a model for a single county because movement across those counties is fluid, especially in certain parts of the state. So really trying to figure out what meaningful regions would look like and how to model transmission in those regions is something that we've really, I think, been struggling with. Obviously, the metro area is a region that is easier to focus on, perhaps the mountain communities. Once we get beyond that, it's hard to sort of figure out how to appropriately, slice and dice the state.
A number of questions, not surprisingly, relate to when the peak is, and I guess then the sort of longer range about more peaks and what will happen. And I think, Beth, maybe you can speak to this, and then of course, Rachel, what actions are taken will determine what we see after we hit a peak for the current epidemic curve. So Beth, and then Rachel, perhaps.
So I think what we are not certain when the peak will be definitively. I think what we can say is that if there is a modest kind of mid-range social distancing scenario, the peak will take a while and it will be fairly catastrophic. If there is a large amount of social distancing happening right now, which you know, cell phone data and other things indicate may be the case, then we should see a peak around now or pretty soon, and that peak won't be catastrophic. And then there is this large question of what do we do after that peak, because that, if we are not careful, may not be the only peak that occurs because there is a large potential susceptible population.
Rachel?
Yeah, and that right now is one of our priorities, is really trying to plan for what we call post-suppression will look like. So if you call the phase we're in right now a phase where we're attempting to suppress transmission through extensive social distancing strategies, the stay-at-home order, you know, we hope to see a reduction in cases over time and then get back to a case count on a daily basis that we can really respond to with the disease control strategies that I outlined. So things like isolation, quarantine, rapid testing, responding to those results, perhaps some other strategies, some level of social distancing that we can put in place to allow things to open back up, to find a new normal perhaps, and figure out, you know, what menu of choices we can use to, you know, let the economy get going again, let people's lives return to more normal while still really controlling the amount of transmission that's happening in the state.
And I will comment that models will be important in guiding that strategy. Beth commented on the IHME model, which essentially has not yet looked at what happens after the initial epidemic curve. So as much prominence as that is received, it hasn't yet become a tool for addressing the consequences of relaxing different strategies. It shows us the one peak that is going on and then how it might decline. We have a lot of questions, Rachel, related to what will happen, and some of them relate to the use of basic epidemiological tools, contact tracing, and testing. And you might just speak to what you think might happen there, and there's an interest in what our testing capacity is and how it will get ramped up. And so I think if you want to speak generally to sort of what will happen later and what you anticipate CDPHE might do.
Mm-hmm. Yeah, so much of the effort of that incident command structure that I showed in the slide is really dedicated to acquiring the resources and tools that we need to be able to respond appropriately and use disease control strategies in place of, you know, this extreme social distancing that we have right now. And so what we're working on is acquiring the PPE that we need for our healthcare system, expanding the capacity of our healthcare system, acquiring the testing reagents, and ensuring we have the laboratory space to have these tests done. And all of that, I mean, that includes so many parts, right? It's the swabs, it's the viral transport media, it's the personnel in those labs, it's the courier to get the specimen to a laboratory. It's all of those pieces. So really trying to stand all of that up. And a really important part of all of this is also ensuring we have places for people to go to get tested. So working on creating that network in the state and having all of those pieces in place when we're really ready to start backing off on the amount of social distancing we have right now.
Okay, and I want to circle back, Beth, for a moment. There's some very good questions about how much will we be able to, and this goes with the social distancing question, how much will we be able to pin down what different interventions have done? For example, a question came up about asking people to use masks and other specific modalities. And clearly, it would be great if we could parse those out one by one, but can we?
So, I mean, one of the beauties and limitations of a model is you can run the model using a range of different scenarios. So we could run the model assuming some reduction in infectiousness from asymptomatic individuals if they're wearing a mask. Those estimates will be sensitive to how effective we think mask wearing by the general public will be. I mean, we've been working to try to come up with scenarios such as that. What are the different scenarios we should model moving forward, and how good is the evidence to support those scenarios? You know, what can we assume if everybody wears a mask in terms of reduction of infectiousness?
Okay. And Rachel, there's a fair number of questions about rural areas and capacity there, and how strategies, contact tracing, testing, et cetera, could be brought into, you know, much more sparsely populated large areas.
Yeah, absolutely. So there is certainly a difference in public health infrastructure in our metro area communities versus our rural communities. And I think at the state level, what we're really trying to do is build the tools and the capacity to really meet each local public health agency where they are. So we know that the needs in our urban communities might be very different than they might be in our rural communities, but really trying to ensure that all local public health agencies in the state and all communities in the state have the infrastructure, the workforce, the tools, the testing sites, the ability to do investigations and issue isolation and quarantine recommendations to individuals and monitor those individuals that is needed. So I think it takes the state working with our local public health partners to figure out what is needed in each jurisdiction, and making sure that we're building tools to support all of those functions for all types of jurisdictions.
Okay. And perhaps this is a general issue that somebody raised, and I'll read a little bit of it because clearly this is an important driver. Is anyone working on the secondary health impacts? And I think that is, you know, all the consequences of the economics, staying at home, social disruption, anxiety, depression, and so on. I mean, if you took a real health impact assessment perspective here, you'd be looking broadly, and I think fair enough, our model captures one very important piece of what is driving health, but there's much more. You know, Rachel, maybe can you speak to what CDPHE or others may be doing more broadly, or what you're aware of?
Yeah, so that is certainly a challenge in that we are, you know, obviously using an incredible amount of resources right now to respond to COVID-19. We do have continuity of operations plans in place to make sure that we are not neglecting other conditions, especially other health impacts that could be resulting from COVID-19, so byproducts of COVID-19 and social distancing. And so certainly the department is working on all of that. And I think it's challenging right now to meet all of the demands, but certainly continuing to work on better understanding the impacts of this pandemic, you know, beyond just the infectious disease components of it is obviously really important work.
Right. While we're with the testing, here's a question. States and localities seem to be pursuing different types of tests from different sources. How will this variability impact post-suppression strategies?
Well, I think it depends on what the question is. So there's obviously PCR and antigen-based testing, and then there's serology. And I think there's a place for both. I think really most of our testing for acute disease response really needs to be based on antigen testing and PCR-based testing. We're more likely to see positive results from that testing early on in illness. And so that's really, I think, the focus right now is ensuring access to that type of testing throughout the state to inform surveillance and to guide clinical decision-making and guide disease control strategies. But we are also looking at how to use serosurvey data. So how to use serologic data to really try and understand what percentage of the population has been infected we're really still trying to gain an understanding of what immunity looks like following this infection. And so without having a good understanding of what immunity looks like, is it short-term, is it long-term, is there protective immunity only in a certain percentage of the population? We really need to answer, I think, a lot of those questions before we have really a clear path forward with how to use serosurvey data.
Okay. There's a couple of questions that relate to specific outbreaks in populations, so those in long-term care facility. And there's a question about meatpacking facilities, which of course has been an issue here, but elsewhere with a major facility closed down today. And I guess from the epidemiological side, this gets at how we're going to deal with these hotspots. And, again, something that's not captured right now in the detail in our models, and some of the agent-based models that Beth discussed could, in fact, be brought to bear in those situations, but we're not doing that kind of work. But Rachel, do you want to talk about these hotspot challenges?
Yeah, so obviously there's going to be an ongoing sort of background level of disease transmission in the state. Even once we are further into suppression, there'll still be that background rate of disease, and controlling outbreaks as they occur is certainly going to be a priority, and particularly outbreaks that are occurring in workplaces that are considered critical infrastructure are going to be a challenge, because this is where we get back to balancing the economics and the epi and disease control part of this, in that we need these critical businesses to be functioning, producing food, producing energy, so we can ensure that infrastructure remains in the country for us to allow to turn the lights on and feed our families. So we need that infrastructure in place. So we do need to have aggressive disease control measures that we can, use when we identify an outbreak, ideally identifying those outbreaks early and intervening early to prevent them from becoming larger outbreaks. And so we are working with CDC to develop some more clear guidance around workplace outbreaks and responding to those, especially when they're occurring in that critical infrastructure setting.
There's a question about respiratory protection that I'll take on, and then I'm going to turn to you both for any wrap-up comments that you want to make. But this question about masks, we looked at this literature last week on where do we think the virus is. Is it just in the larger droplets, the kind that most masks would keep from being spewed forth, or is it also in smaller particles that might remain airborne for a longer period of time? And I think right now the evidence would seem to say both, and that has important implications for respiratory protection. The masks that we use that are not N95 masks, but the things that we've put together or we have are to protect others. They're to keep those secretions that may be infectious from coming in contact with others when we cough or sneeze, which are forceful propulsions of materials from our respiratory tract. So let me turn to Beth and then Rachel for any wrap-up comments that you may have. See, Beth?
I just want to say thanks for all the really thoughtful questions. I really do feel like this is this unprecedented time. And I will end on a hopeful note by saying that there has been this amazing sense of collaboration within our modeling team, between the people in the modeling team and the state, between other scientists that we've reached out to for input on parameters in their papers. And that does make me hopeful that we will find a way forward that is positive for health, both in terms of COVID and all the other health sequelae.
Rachel?
Yeah, that's great. Thank you, Beth. And I would like to just thank the School of Public Health and the university for the incredible partnership. Obviously, there's resources and infrastructure that exist in academic institutions that don't necessarily exist in governmental public health. And it's really been an incredible partnership to really work with this modeling team and have access to them to really answer really important questions and get the data we need to really make decisions and inform policy here in the state. So very appreciative for your
Great.
help.
So I want to give my thanks to both Beth and Rachel. This would be where we have a round of applause if we did such things on Zoom conference. I just want to make a few closing comments and touch on a few things that others have raised. One was, are we using knowledge from prior epidemics here? Absolutely. And this is where these models come from, all the basic steps. So we're drawing now on literally centuries of experience in how to address epidemics. This epidemic, like all others, and this speaks to concerns raised, does not affect our populations equally. I write a comment every week, and last week I had this sentence that said, epidemics thrive on inequity. And this one is no different. And we know that our population is differentially affected, and we have to certainly take that into account in all our strategies to protect everyone. And one questioner really highlighted the goal. We want to have everyone in the end immune to this virus. And we want to get there with as little morbidity and mortality as possible. And that's really the overall goal of everyone. So I want to thank you all for participating today. And as time goes on, we'll come back and do this again as we move forward in our Colorado effort to end the epidemic. So thank you all for being with us, and stay well.